Please acknowledge your presence whenever I call your name. Dr. David Reeves.
Here.
Dr. James Risch.
Here.
Mr. Benny Hubbard.
Here.
Dr. Billy Long.
Here.
Dr. Charles O'Mara.
Here.
Ms. Phaedra Cole.
Here.
Mr. Lee Bond. Dr. Justin Brewer.
Here.
Dr. Jasmine Chapman.
Here.
Dr. Thomas Dobbs. And Mr. Kent Nico.
Here.
All right, thank you, everybody. It does appear we have a quorum present. A few housekeeping items to start off with. The first one, just mention that you do have travel forms in your folder. Again, if you'll fill those out for us, we'll get that paid. The travel should have been paid to you from the last meeting already. If you've not received that, let us know, and we'll get that taken care of for you. The second housekeeping item that I'll mention is please speak into your microphone. That's the only way that the individuals online can hear us. It also helps the others in the room to be able to hear as well. So you should have a microphone in front of you. Please speak into the microphone whenever you're speaking. We do have a couple of individuals substituting in today for the medical directors for a couple of the MCOs. I believe Michael Parnell is with us on behalf of United Healthcare. I also believe that Dr. Prasad is on, but we also have Richard Jones substituting for Dr. Joyner with Molina. We do have Dr. Irwin in attendance over here with Magnolia. Also want to acknowledge that we do have Chairman Hob Bryan with us. He's the chairman of the Senate Public Health Committee. Welcome, Senator Bryan. So we'll move to the next item on the agenda, which is the approval of the meeting minutes from June 25th. You should have received those in an email prior to the meeting. You also should have a copy of the minutes in the folder in front of you. I'll give you a few minutes to find those if you need it. And at the appropriate time, we would entertain a motion to adopt those minutes.
I so move. Second.
Dr. Long moves, Dr. O'Mara seconds. All in favor say aye.
Aye.
All opposed, no. The ayes have it. Moving on to the next item of the agenda, the old business is the election of the chairperson for the Medical Care Advisory Committee. To begin, I just wanted to make you aware of a few things with the chairperson. The chairman is elected by the voting members annually, and according to 43-13-107-3E, the statute that establishes the committee, shall not serve for more than 2 consecutive years. At this time, I would recommend a motion to open the nomination for a chairman of the Medical Care Advisory Committee.
This is Kent Nico. I'd like to nominate Dr. David Reeves, a practicing pediatrician.
Mr. Nico nominates Dr. David Reeves. Are there any other nominations?
I second the nomination.
Dr. O'Mara seconds the nomination for Dr. David Reeves. Are there any further nominations? Are there any further nominations? Hearing none, we'll move to elect Dr. David Reeves as the chairperson for the Medical Care Advisory Committee. All in favor, say aye.
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 All opposed, no. The ayes have it. Thank you, Dr. Reeves. Congratulations or condolences. We look forward to working with you. Moving to new business. Is there any new business that needs to come before the committee today? One thing that I would like to mention is that, again, we are a resource for you. This is your committee. We're here to provide any information that you need in order to make sound policy recommendations to the Division of Medicaid. So as issues come up that you want to discuss or address, please let us know. We'll be happy to provide any information for you. What I would ask the committee to consider before the next meeting is what type of information would be helpful to see going forward. In the next meeting, would you like to see basic Medicaid information? Are there specific topics that you would like to address? What would be the most helpful thing to see from the Division of Medicaid for the committee? You don't have to answer that today. If you have some ideas, we will certainly entertain those. But certainly before the next committee meeting, any information that you would like to see from us, we would certainly appreciate. I also want to acknowledge that Chairman Hobson has joined us, Chairman Briggs Hobson, who's the Senate Appropriations Committee Chairman. Welcome.
Hey, good afternoon. I'm sorry I'm a little bit late. This is Thomas. I did have a specific question about reimbursement for family planning services for private docs. And whenever there's an appropriate time to ask that question, that would be great.
Sure, go ahead, Dr. Dobbs.
Yeah, so I was contacted by an OBGYN physician who's in private practice, and the reimbursement rate for the Depo-Provera is below his cost and looks below retail costs that we could find that's not 340B. And so part of my question is, are there ways to remedy that in the context of y'all's restrictions from raising reimbursements? Or is that something that's going to be unfixable in the current fiscal year?
Dr. Dobbs, is that a question for the division?
Yes, sir.
I'm not sure that we're prepared to answer that today. Is that something that you could shoot to the group in an email form and we'll get back to the group on that?
Yes, sir, of course.
We'll be happy to look into that for you.
Hi, this is Jim Risch too. I wanted, to put something on the agenda for later for discussion, just some, I think it would be helpful among most practicing physicians to review the observation process and criteria that's set forth by the division. If we could put that maybe on a future meeting agenda, I would appreciate it.
Yeah, Dr. Risch, you're referring to the hospital observation policy?
I am.
Sure. Mr. Chairman, if that's okay with you and the committee, we would be happy to add that to the next agenda. Is it Senator Bryan? It should already be on. You may have to turn it a little bit more towards you. There it is. Sorry about that. We thought all the mics were on.
I never have understood machinery. I'm not sure where the agenda for the committee has traditionally come from. The meetings that I was able to attend last year or year before, whatever it was, I thought were very productive. There were problems that were arising involving reimbursement, about procedures that managed care companies had. And I was under the impression that at least some progress was being made on getting some of those matters resolved. And I guess I thought both last month and this month that we would sort of pick up where my recollection is that left off, and that there were a number of continuing matters of concern that we would be addressing at the meetings. But if what we're doing now is discussing what the committee might consider, of course, as those of you with Medicaid are painfully aware, the legislature in its wisdom included in the legislation that was passed last year some legislation about freezing rates which seems to have caused some confusion. And I don't know if this is the proper place to look at the ramifications of that. But I do know that when we first started managed care, the representations made by the managed care companies were not that they would reduce reimbursement, but that they would save money by making more effective use of funds, that they would be able to, through various preventive methods, through reducing use of emergency rooms and on and on and on, managing care for the chronically ill, that they would be able to hold down Medicaid expenditures, and the savings would not come from reducing reimbursement rates. So that historically, I believe there was language in the Medicaid statute, which the purpose of which was to simply say, you can't reduce rates below what they were, at least not in the context of managed care. And I know that I'm babbling and in general terms, and I'm sure there are a string of yes buts a mile long that I don't remember, but that was sort of the general idea. So I don't know what language got in this conference report. I guess if someone wanted to be tacky, he could point out that I signed the thing. But conferences work differently these days. But I don't know if there are ramifications from that. I don't know if there are unintended consequences. I don't know if there are intended consequences. I don't know if that's something we could discuss or not, but I just mentioned that. The other thing I would mention, which is perhaps related or perhaps not, is the continuing issue of Medicaid reimbursement in the area of mental health. As you know, due to both legislation that we passed and due to the pending federal lawsuit, there are a number of changes being made in the delivery of mental health care, more gradual than dramatic, but nevertheless, we're making changes. And I keep hearing things about reimbursement rates in that area. So again, I don't know if either of those two things are appropriate for this committee, but since we're here, I'll just mention those.
Thank you, Senator Bryan. Yeah, we can address all of those things in the future. And I agree, the Division of Medicaid has had a tremendous relationship with this committee over the last several years. Unfortunately, the previous members' terms expired with the term of the governor. We had a few administrative tasks that we needed to take care of before we could dive into the meaty issues. But the issues of mental health reimbursement and managed care, the statute or the language in the statute that you were referring to about the tie to Medicaid reimbursement, I believe is still there. And you're correct, Mr. Chairman, there was some language that was added into the conference report that froze reimbursement rates effective July the 1st of 2021. And we would be happy to, address the concerns there and the issues that we foresee going forward with that language.
Well, again, it may be on the scope of this committee, but there are constant threats of a special session. And it's my understanding that once there is a special session, there immediately arise dozens of little matters that could be handled at the special session, separate and apart from the main part of the special session, which I guess is a variation on the theme of when the legislature's in session, no one is safe. But there might be an opportunity if that language has caused unanticipated difficulties. If there's to be a special session, and if there is, I don't know that there is, if there is a relatively simple fix for that, there might be an opportunity to do that at the special session. And again, this may be beyond the scope of this committee, but anyway.
It's certainly something that can be discussed with the committee, and the committee can make a recommendation to the legislature at any time. I believe that this committee has had a really good relationship with the legislature in the past. And from what I remember, the legislature has appreciated the input of this committee previously. So I don't think it's outside of the scope of this committee to have that discussion and make a recommendation to the legislature. But again, I think I would leave that to the chairman of the committee. I don't want to speak out of turn.
No, I think we can address any of that concerns that people have. One of the questions that comes up on the coast, and this is for our managed care people, one of the problems, since we're talking about mental health, we have difficulty referring to some of the private practitioners. Some of them are on like one of the managed health care policies, but not on others. And so it's real difficult to get people in. Is there ongoing outreach from Magnolia and Molina to some of the mental health providers on the coast just to get them signed up?
If the individuals from the managed care organizations are prepared to address that, that's something we can do. But I would ask Dr. Irwin, if you could please step up to a microphone so the members online can hear you. I believe the one at the end of the table is on.
Well, I guess since I'm the only one here, I get to answer for everybody. No. So we are always actively looking at network adequacy gaps, and we monitor that on a quarterly basis. We have monthly credentialing committee meetings. And so as far as I know, we have no gaps on the coast. I know all the major hospital systems are in network, and the majority of our both primary care and specialist needs are met by all, exceed all of our required standards. So if there's specific areas or specific specialties that we need to address, I'll be happy to go back and get the information that we need and see what we do. But the coast is one of our more heavily populated in-network areas of the state. Is there?
Well, the big problem is that our private practitioners of psychology and psychiatry, a lot of them are not enrolled in all the managed care entities. And the issue is, I don't know if the committee is aware, but Gulf Coast Mental Health Center fell apart through mismanagement. They were bankrupt and have been, administration has been taken over by the Pine Belt Mental Health Society. The problem we have is that Gulfport Behavioral Health has pulled back and is not doing anything but inpatient. And then they just dump outpatient onto Pine Belt Mental Health Center, and it's taking, after they get out, 2 to 3 months to get people appointments. And so as a result, a lot of practitioners, including myself, are having to manage medications that we're not familiar with always. And there's just gaps. And when we tried to refer people to some of the private psychologists and private psychiatrists, they're either, it's a hodgepodge of who their managed care entities. They don't take, nobody takes everything from what I've been able to find out when it comes to pediatric, psychological and psychiatric services. So it's just a concern.
Mental health care is a concern for the whole state. As you know, we have a huge parity of providers in general in this state, especially child and adolescent psychiatrists. And so we try to actively to get anyone we can in our network. But there are steps we look through. We don't just there have to be licensed, they have to be credentialed, but also we look at quality measures too. And as we've grown and we have more than enough network adequacy, we have started looking at quality and making decisions based on quality, because we want the highest quality for our members. And if someone is not providing that high quality, we have no hesitation to remove them from our network. And we share that with them. And there's a committee that we use that's made of external providers as well as internal medical directors. But external providers, there's about 8 of them that sit on this committee and help make those decisions. So it's not just me as the chief medical officer deciding who has high quality or not. This is a public meeting that has you know, a set form that we have to follow and stuff. But if there, like I said, if you want a specific report or anything, just I'll be happy to bring that back and at whenever time in the future present that where we have actual data, not just anecdotal data that I'm giving today.
Thank you.
Yeah, this is Jim Risch. I think this is an area where we really need to put some interest and efforts in looking as to how we could improve it, because I think not only on the outpatient side, but on the inpatient side, making sure that patients that are discharged have access to follow-up care within a reasonable period of time is very crucial to preventing rapid readmissions, which we see in this population. So I think if we could approach that even more holistically in the frame of readmissions, that would be time well spent.
Will, I'd like to speak to what Chairman Bryan spoke to about the rate freeze, if we can. I know that affects all Medicaid providers, is my understanding with the legislative process, what they pass. And being in the long-term care business, I know you and Drew and Tracy understand our position on that, because freezing our rates in a cost reimbursed system like we're in is devastating to long-term care. And I have heard rumors about a special session that may come up. I was like for the committee to consider, if we could, taking a position on that today, because if we wait until the next quarter, it may be after the special session has been called. And if we could take that action today and pass that on to the legislators and to the governor, I think that would be appropriate. And I'd like for the committee to consider that.
Certainly, that's up to the committee and the chairman. Mr. Chairman, entertain a motion if you want to.
Yeah, if you would like to make that motion, I think that would be fine. That we is your motion that we rescind the freezing of the rates? I'm sorry. Is your motion that we ask the legislature to rescind the freezing of the rates?
Yes.
Okay. Do we have a second?
This is Kent Nico. I'll second that motion.
Okay. And so I guess to state the motion, it is the committee asked the legislature to repeal
Retract
the freezing of the rates,
3-year rate freeze.
the 3-year rate freeze. Okay. Yes, sir.
Thank you, Mr. Chairman. And this is Senator Hobson. Can I get a little bit more information? I mean, I heard what Senator Bryan said, but a little bit more information as to the history of the rate freeze. And also, I would ask, I'm looking down at the Director of Medicaid. Is this related to the language that was in the bill that passed that has created difficulties for the Division of Medicaid? Are we talking about the same issue, or is this something that's just tangentially related to that, or not related at all?
It is. I think what's being discussed is 4313-117D, the provision that says that no payments or rates of reimbursement may be increased, decreased, or otherwise changed from the levels in effect on July 1 of 2021.
Okay, and the motion, as I understood it, was for a 3-year.
As I understand it, that was a 3-year freeze. Is that correct?
That's correct. It's in place with a sunset of 117. That section would expire in 2024, so it is essentially up to a 3-year freeze. Without, I mean, part of that is they can't be changed unless there is an amendment to the section, by the legislature.
And correct me if I'm wrong, but the bill that was passed last year had a 1-year repealer on it?
3-year repealer.
3-year. Okay. Was there any language in that bill that was subject to a 1-year repealer, or was it all 3 years?
I believe it was all 3 years.
Okay. Thank you.
And we asked, you asked for the history of that. I'd like to know why that was done.
Why, what was done, the repealer?
Why was it frozen? Why were the rates frozen? I mean, was there,
Well,
we just had a shortage in the Medicaid budget, or was there money appropriated other places, or?
unlike Senator Bryan, I was not even a conferee on that bill, so
I mean,
I don't recall specifically. I'm sure either Senator Bryan or our Director of Medicaid, Mr. Snyder, could probably answer that question, but I was not heavily involved in the discussions on on why that was done. I mean, I do know relative to repealers and consideration of Medicaid traditionally, and Senator Bryan can speak to this with much more knowledge and experience than I, that traditionally, the Medicaid tech bill comes up for reconsideration every 3 or 4 years historically. But I'll let one of these guys answer that. They probably have more information than I do.
Yes, sir.
Well, just looking around the room, I don't see anyone here from the House. So sort of the default setting would be to blame the House for anything anybody's uncomfortable with. But actually, I don't know what the intent was. And anytime you're talking about legislative intent, of course, there's the mens rea issue in the first place. But I believe it to be the case that whatever the motivation for that language, the way it was written did not accomplish whatever it was hoped to be accomplished. And I do know that there is a continuing concern among some of us that reimbursement rates not be reduced because that was not the bargain that was originally made with the managed care companies. I think there are probably arguments that here, yonder, and there are some rates which need to be reduced because they're out of line, but we've never been able to fine tune those things. But I think we're in a vacuum trying to guess what the motivation was, unless our friends from Medicaid in some of their conversations have been able to determine that motivation.
Anything would be speculation, and we became aware of this language, when the conference report was being presented on the floor. So one caveat on the history. There was some similar language in the statute in the 1980s until probably 2018, but it was removed in 18. But what was put back in the statute is was missing some important exclusions. So.
That was going to be my question. Could the committee consider a motion to ask the legislators if there is a special session to review 4313-117B for the possibility of an amendment that would address exclusions such as long-term nursing home?
May I say something? Kent, did you say 4313-117B or 4313-117D?
I'm sorry, D. I'm trying to read my writing here, Drew. Sorry about that. Yeah, I agree with what the chairman said and what the executive director mentioned, that I believe the all-encompassing freeze for the 3-year period for any participant in Medicaid, what may have not been the intent, such as nursing homes where that per diem is related to the cost of care on a falling 2-year. So this will freeze based on care. For example, during COVID, when the expenses were higher, if in a 3-year period, that expense for that per diem would not go up. So, I would ask them to reconsider. That would be one of the amendments, and some others, as mentioned, may also be considered as a carve out or exclusion.
Okay.
I think so. I think they would have to substitute. They would have to withdraw the original motion. And substitute.
Sorry, we were discussing the rules on the original motion and doing a substitute motion. I think that if we were going to make a different motion or substitute motion, Mr. Herbert, you would need to withdraw your original motion, and then there would need to be a vote to adopt the other motion.
Could you repeat what Ken's motion would be?
Mr. Nico, could you repeat what your motion would be?
To ask the legislature to consider an exclusion or a carve out for subcategories under the Medicaid freeze for 3 years, such as nursing home per diems.
Just a question. This is for our Medicaid. You were talking about different parts of the bill, 4313, 117B, and then is there a different one, 4313, 117E? Is that a separate?
The language I think that is being discussed is 4313, 117D, as in dog.
D. Okay.
And what's the difference in that and what my motion was, Will?
I believe that Mr. Nico's motion is much more specific to which providers would be subject to that freeze. Mr. Nico, I'll let you clarify that if I'm mistaken, but it sounds like that certain providers would be carved out of that freeze, whereas Mr. Hubbard's motion was to rescind that section altogether.
My motion was to amend to allow an exclusion or a carve out, such as Drew mentioned. I use as an example the nursing home per diem.
Okay. Wrap my head around how to word this motion.
I think in order to vote on that, Mr. Hubbard would have to withdraw his first. We may, if not, we would need to vote on Mr. Hubbard's motion first.
Would it be unusual for the legislature to carve out certain providers, do you think? Carve out certain providers for the rate freeze?
Probably, be my guess, would you agree, Senator? Carve out certain providers would be unusual.
I'm thinking this usually doesn't last long and it'll pass and I'll be okay. I'm just wondering, since we're all guessing about the motivation behind the language, that there might be something to be said for suggesting that somebody review it and make it more direct or specific or whatever, rather than this committee trying to figure out what the solution should be. I think that it's my understanding from talking to the people at Medicaid and talking to providers, the language has had some unintended consequences, and maybe there's something to be said for simply reviewing the language and amending it without our trying to figure out what that amendment should be, without anyone here who can speak on behalf of the accused.
Understood. I'll withdraw my sub motion and just allow Mr. Hubbard's motion to ask the legislature in a special session to withdraw the freeze.
I mean, I think there's, is this on or not? Did that do it? So, you know, the mental health area as well as the nursing home area are two areas that we've discussed here that seem to be shortchanged with providers in mental health and so forth. So, yeah, I mean, I think the whole issue needs to be, I think, considered in a package somehow. Is there a way that we can entice more mental health providers to participate? Or maybe we have enough. We just heard on the coast they have enough. I don't know if that's true or not. But there may be pockets of providers that need, you know, that are going to, it's going to take maybe a little bit of increase maybe in the rate. And, but in this bill, if I understood it correctly, it's, you can't decrease or increase, it's frozen. And so anyway, I think, you know, what my suggestion would be, I don't have a motion, but my suggestion would be to just review the entire bill and with all of these points that we've made here today may be included. I mean, I think there are legitimate points that have been made. I just don't know what the fix might be. I don't know.
I'll add to that by saying it. I'm sensing from the discussion that we need more information before we make a definitive recommendation here. And I'll go back to a comment you made, Mr. Hubbard, earlier about the time-sensitive nature of this. Would you mention that again?
I did, because if they have a special session, we don't meet for 3 more months, the governor may call a special session prior to that.
Right.
That's the reason I was concerned about the urgency of it.
So when will our next meeting be as a committee? That we could meet sooner rather than what we anticipate a quarterly basis with more information.
Yeah, the
I'm
statute.
just a little uncomfortable about making a decision about this as a committee. I'm speaking for myself personally without more information.
Would it be appropriate for us to amend your recommendation to ask the legislature to review and consider changes in the rate freeze enacted in 4313-117, whatever D, rather than just ask him to rescind it, since we're not sure what's in it. But if we ask him to review the whole section and consider changes, would that be appropriate, do you think?
As long as that doesn't carve out particular providers, I think it would be. If you start carving out different types of providers, I think that's going to be very difficult for the legislature to do, based on my.
Because essentially it's pitting one group of specialists against another, and I think you're right. The legislature doesn't like fights between different parts of medicine. I don't think our legislators will disagree with that. So that was, instead of carving out, just say the committee would, because we have had complaints about the rate freeze, we asked the legislature to please review and consider changes in section 4313-117D. Would that be an appropriate?
I would just leave out the section and ask them to reconsider
the whole thing?
the rate freeze section. I don't think we want them to review the whole technical amendments bill. That's not going to happen, I don't think. But just the rate freeze section is what the concern is. And not just from long-term care, other providers as well.
Okay. Okay, so review and consider changes in the rate freeze.
Yes.
Okay, so you would accept that change in the proposal?
Yes.
Okay. Any other discussion? Anybody speak their mind? Do you think that is a fair? When I run a meeting, I always try and get everybody's viewpoint and then kind of come up with a consensus of what we all think. So that's what I'm asking is do you think that's fair? Do you have other changes or other thoughts?
I think that's fair. which we're not making specific recommendations for changes that some of us are not comfortable for lack of information. So, yeah, I'd be fine with that.
And I agree, Jasmine Chapman.
Yeah, this is Rich. I agree as well.
I agree that accomplishes the task.
Okay. All right. So we have a motion that we are asking the legislature, either in special session or regular session, to review and consider, to review the rate freeze and consider
To review the rate freeze language in the technical amendments bill.
in the technical, to review the
We're
rate
requesting,
freeze.
and somehow that has to get to the governor as well, because he would have to add it to the call, right?
Rate freeze section of the Medicaid, it's called the Medicaid Tech Bill. Is that correct?
That's a fairly common term for it, but it's Mississippi Code Section 4313-117 is the statute in question.
So, okay, so we're asking the legislature to review the rate freeze in Medicaid. I'm trying to get the language right, I'm sorry.
And Mississippi Code Section 4313-117.
Mississippi Code, Section 4313-117.
Yes, sir.
Okay. So, but that is we have the amended motion asking the legislature to review the rate freeze section in Mississippi Code Section 4313-117. Do we have a second?
Second.
All in favor?
Aye.
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 All opposed? Okay, the motion is carried. Do we have any other new business anyone would like to bring before the committee at this time? Okay. Anything from y'all?
No, sir, you're rocking and rolling.
So could we request that the Division of Medicaid provide more information at our next meeting concerning all of this?
Certainly.
Okay.
Yeah. Yeah, that, I suppose this whole section is done every 3 or 4 years, the Medicaid Tech Bill, as they call it.
Yep. Roughly
Okay.
every 3 to 4 years, yes, sir, unless the legislature decides to take it up before then. But typically, it's the extent of the repealer that's placed in there, which is 3 to 4 years.
Much as I hate to read all kind of legislative acts, could we perhaps get copies of that
Certainly.
section for the
Yes,
committee?
sir.
So at least I can read through it and see if I can figure out what it says?
Certainly.
Thank you. Any other questions to come before the committee? Does anyone who is online, do they have anything they would like to bring before the committee?
I have a question,
Yes, sir.
another question. So how does the Division of Medicaid interact with the Medicaid population in our state regarding vaccinations for COVID? In other words, at our next meeting, is there data that says a certain percentage of Medicaid recipients have been vaccinated? Or, is that, everybody's getting it free, right? So, I mean, but I don't know that Medicaid's not paying for that. I don't guess.
Let's do this. One ongoing issue that we have with our numbers is because, and I think it is a smart public policy move that we're not asking for payer-specific information when the health department or other providers are putting shots in arms. But it does create some data challenges for the division, and we're in the process of talking to the Department of Health about some streamlined ways to get more global information, so we can we have a better estimate of what our numbers are. This is not just a Mississippi issue related to payer-specific vaccination data, but it's other states are wrestling with it as well. But we need to know, that information. We also don't need to, bog down the health department right now with really cumbersome manual processes. So a lot of the talk is around, is there a way to do that quickly? I know each managed care plan is also real interested in getting their members vaccinated and trying to get that type of information. So we'll work on that and get back to you on where there may not be a definitive set of numbers, but perhaps there will be a little bit more of these barriers that have been identified. A few of them have been removed.
Yeah, and I'm sure just from your standpoint, it's easy with children because everything's done through the Vaccine for Children's program. But with VFC being distributed through the health department and the hospitals and different clinics, I'm sure it's difficult for Medicaid to judge because you're not paying for anything. Correct? Yes.
Yeah, and that's been a challenge on getting some good lab and testing information from our dually eligibles, because what we get in Medicare data is usually the portion that Medicaid pays, but when there's not a co-insurance or deductible portion to pay, like there is with some of the laboratory testing related to COVID, we don't see that information. So our data folks, something we've been wrestling with since March of 2020.
Hey, and this is Thomas. From the Department of Health perspective, to improve access, we didn't really collect any payer data for our drive-throughs. It was all about efficiency, and that was the most efficient mechanism for getting folks vaccinated. We just had the minimum data set you needed, and we did it with zero, insurance information. But we do have a database that we can work with the Division of Medicaid to make sure that we can, cross-reference the beneficiaries to see where those rates are.
Do we have any other issues that anyone would like to bring forward to the committee today? Okay. Anyone online have anything that they would like to bring up?
Oh, it looks like we filled our plate for the next meeting anyway, so I don't have anything else.
Okay, thank you, Dr. Risch. Anyone from the Division of Medicaid or from our managed care people here that have any questions for the committee or any concerns to bring up?
This is Rich Jones with Molina. I don't have anything at this time.
Okay. All right, so I guess the next order of business is to try and set the next meeting. Okay, and so it's quarterly, correct? So, and you're going through starting, where do your quarters rotate? July, August, January, what are we looking at?
January through March, April, May, June, July, August, September, October, November, December. It's calendar quarter.
Okay.
But the statute only requires that the committee meet quarterly. The committee is feel free to meet more frequently than that.
Okay. So we need at least to set something for October through December, correct? Yeah, July, August, September, yeah. Okay, so I know that's far in the future. I'm sure nobody wants to get too involved with things at Christmas season or around Thanksgiving. So we're probably looking at that 6 weeks from October through the middle of November. Does anyone have any preferences? Realizing that, of course, as times progress, we may have to change things, but would y'all prefer October or November? Does anybody have any preferences?
I would suggest October.
I would agree with that.
Okay. So, first Friday in October, which is, when is that? We all bring our phones out. Okay. Does anybody at this point have any objections to meeting October the 1st at 1 p.m.? Okay, then we will tentatively set that meeting. We will confirm it about a month before. We'll notify everybody on September, the first week of September, and make sure that something didn't come up like, some important football game people don't want to miss or who knows what. Used to be easier in the old days when I was in medical school and State and Ole Miss played all their games in Jackson. It wouldn't have been an issue. Which was great if you were up here at the time. Then we will tentatively set the meeting for October 1st at 1 p.m. Are there any other business that anyone would like to bring up or propose? Okay, do we have a motion for adjournment?
So moved.
We have a second?
Second.
Second, okay. The motion having been made and seconded, all in favor say aye. Aye.
Aye.
Okay, the meeting is adjourned. Thank you all for your attendance and attentiveness.
To chair?
Yeah.
Hey, y'all have a great weekend.
Originally from Oxford. They made you move to Tupelo.
Got out of medical